Welcome, Zach Couples from ZachCouples.com, and I want to thank you guys for getting access to this talk, however you do, because I think it's a very important talk on pain and what we're thinking about in regards to current pain, explanations, and educational processes. I first gave this talk when I was speaking in the land of China, and I figured you guys probably didn't want to spend 4 hours listening to a talk where I say 2 sentences and then it's translated and then I say 2 more sentences and back and forth, right? So I decided to re-record this talk for you guys so it's streamlined and you get everything you need out of it. And the reason why I decided to talk on this topic is because pain is an incredibly important and big problem for us today in healthcare. The amount of dollars in the West that we spend on pain is equal to that of cancer and diabetes combined. That's a sizable amount of money. Moreover, 60% of people who get hurt and experience pain today will be in pain a year from now. So the point being, guys, is we have a problem that we have to deal with. And one of the methods that I'm going to teach you guys to help solve or at least mitigate this problem of pain is through educating people, utilizing what we know about the way pain works. What really got me into this was patients, people that I work with. When I first got out of physical therapy school and I started my orthopedic residency, we discussed treatment paradigms based on a structure at fault model. So you have some structure that's injured and you do some diagnostic testing to implicate a particular structure, and then you do treatments targeted towards that structure. For example, say I hurt my bicep. I resist, ow, right? That would hurt because the muscle's contracting. I stretch the muscle, that would potentially hurt. Sword palpation, probably a bicep problem. Maybe you do treatments that could potentially help that area heal. And we learned this type of thought process for a variety of conditions. Lateral epicondylitis, ankle sprains, facet joint arthritis, all types of things. And for a lot of people, it worked. Until she came in the clinic. I remember this woman very, very well. And she came in, and she was complaining of arm and leg pain. Just everything felt tight and like couldn't open up, and it would just get this wrenching pain in her arms or in her legs anytime she tried to extend any of those extremities. And being the good diagnostician that I was, I tested neurological signs and symptoms or neurological screening, negative. Maybe it's some tension testing, negative. I was at a loss. I didn't know how else I could explain this because it was multiple joints. It couldn't be muscle. Wasn't one joint in particular, right? Was it? I didn't know what to do. So I talked to my instructor at the time about this patient, had him sit in, and we just kind of ran through a session. I said, what's going on? And so, of course, we came to the only conclusion you could come to in this case. It was the thoracic spine. So what did I do? I did my P to A mobilization like a good orthopedic resident. And I said, hey, how you feel? No change. And I didn't help this woman. And it bothered me until this day. And it wasn't until I was exposed to these 3 gentlemen right here, Adrian Lowe, Lorimer Mosley, and David Butler, that patients like her started to make sense. And, well, maybe I didn't have a quick fix for these people. I could at least educate these people in such a manner as to what was going on. And because I had the knowledge now of what was going on with these people, I had many more options and tools at my disposal to help these people be successful and meet their goals, whether it's pain freedom or whether it's performing at the highest level. If you're wondering, I absolutely do look like that with my shirt off. So here's what we're going to talk about today, guys. I'm going to verse you in the history of how we understand or understood pain and how it works. Because I think that that's very, very important to know where we started and where we're at least with today's understandings of neurophysiology and many other systems. This is an incredibly complex topic, and I don't profess to know all the answers or understand it completely. But I want you guys to appreciate that though this is a complex topic, and there's a lot of factors that go into why someone experiences pain versus not, or why someone experiences prolonged pain, we can take this newfound knowledge and educate our clients in a simple, easy to understand fashion to empower them, to help them get over these chronic pain syndromes and allow them to reach their goals. So first, a little bit of history. And we'll start with the biomedical model. This is the model that most of modern medicine uses today to explain why people hurt. And it was purported by French philosopher René Descartes. What Descartes thought was pain occurs and is caused by injury to some type of tissue. And so what does this look like on a model? Check out that model. So I stick my hand in fire. What happens is pain fibers or pain signals come up the arm, making its way to the spinal cord, going up to the brain, telling me I'm in pain. This is how we think of modern medicine. So for example, you have an arthritic knee. I get rid of those joint surfaces via a total knee arthroplasty. That eliminates pain. Life's good. The problem is that there are a lot of painful conditions that this type of explanation can't make sense of. For example, let's look at phantom limb pain. Where are the pain fibers in this case if someone is experiencing pain in a limb that doesn't exist? There's nothing there that could carry signals up to the brain letting you know you're in pain. How about conditions that are painful conditions that persist well beyond normal healing times? We know most tissues in the human body heal in a 4 to 6 month time period. Discs in the spine, 7 to 9. Yet, how many people do we know experience pain well beyond those times, or have the same pain for years? Can't make sense of these things. Lastly, what about emotional pain? Your honey breaks up with you, and you feel physical pain. It hurts. What structure can we implicate there? There is none. Though the fix is a total significant other replacement. But that's besides the point. The point being is, with all of these instances, René Descartes' model can't explain it, and it doesn't fit. We need something more comprehensive. That's where the biopsychosocial model comes into play. This model is good because it looks at many more factors that go into the pain experience. We can illustrate this model via Louis Gifford, rest in peace, Louis Gifford's mature organism model. And so instead of thinking as pain as an input from the tissues, we instead look at it as an output from the brain. And here's how it works. So you get, let me poke on my computer. You have these two things here. You have the environment and you have tissues. These things right here send signals up the spinal cord, or inputs, to the brain, saying, hey, this is going on. The brain then takes that information and scrutinizes it by taking into account genetics, past experiences, beliefs, what we've done in the past for these types of things, and then an output is produced. So there's an alteration in what we're doing from a behavioral standpoint and physiological changes. Pain would fit in on the output side of things, right there. And that's exactly the definition that Lorimer Moseley gave for pain. So pain is a multiple system output activated by the brain based on perceived threat. And so, back to this model, based on the potential threat we may perceive, whether it's environmental or tissue-based, the brain takes that information, weighs it accordingly, and decides the best thing for our survival at this point is to let you know something might be going wrong here, and pain is produced to let you know that. So instead of pain being equal with tissue damage, pain is something that is a result of tissue damage made in order to protect the affected area. So if we contrast the past two models, in the top corner we have the Cartesian model, where you stick your foot in the fire and pain signal travels up your brain letting you know you're in pain. Instead, let's contrast that with the biopsychosocial model, or the modern pain neuroscience model, where you get that same noxious stimulus, not a painful stimulus, but a noxious stimulus, sending signals up to the brain, and then based on a lot of those factors where those arrows are, you get a corresponding output such as pain. And what's really cool is there's many different things that can modulate whether or not you experience that sensation, one, and to what extent that sensation is manifesting. Because there are many cases that I'm sure we can all think of where you have some type of small input and a large pain response, and vice versa. For example, you stub your toe. Ow! Hurts like hell, right? But it's not really an injury. Large pain response, small input. On the flip side, I'm sure we've all heard stories of people who've had their limbs blown off in war times. And what happens with these people? Well, they continue fighting on and don't experience much pain. So it's very cool how multiple systems in the brain can modulate what type of output we experience. Now, within this model, we can classify how someone experiences pain according to three different mechanisms: nociception, neuropathic, or central sensitization. Let's dive into each. First, nociception. We can define nociception as sensory information about noxious stimuli. This is a much more accurate term than saying we're getting pain signals coming up from the periphery. So in the Cartesian model, we think pain signals come up from the periphery and let us know we're in pain. Whereas in this case, nociception, or sensory input saying something noxious is going on, is carried, and then pain is produced by the brain. There's two types of nociceptive pain. There's inflammatory nociception and ischemic nociception. Inflammation's easy, right? You sprain your ankle, inflammatory reaction occurs, that activates nociceptors in the affected region, letting you know you're in trouble, brain produces pain. The ischemic standpoint is a little bit different. So let's go with a different example. Here, ischemia occurs when there is a lack of blood flow to a particular region. And so let's say you sit for a couple hours. I'm sitting. All of a sudden, I do that. I move. Why did I move? I'm glad you asked. So the reason why I move in this case is because I have decreased blood flow to the nerves on my rear. Nociceptive signals are sent up to my brain saying, hey, we're not getting blood flow. And so I get a reaction. I move. That is the output in this case, so blood flow can be restored. In some cases, and maybe sometimes where posture can correlate with pain, if I sustain a posture for a prolonged period of time, there's potential that the tissues could become ischemic, creating nociception, which could potentially result in pain. Nociceptive information is carried by two different nerve fibers, the C fiber and the A delta fiber. The C fiber is a slow sending nerve fiber, and the reason why that is because it lacks myelin. We say it's a non-myelinated nerve, but that's really kind of not necessarily 100% true. And the reason why it's not is because there are Schwann cells surrounding the nerve tract. And so think of myelin as like electrical coating around wires. It allows for conduction to go much faster when that is present. In the C fiber's case, because there was so little, information travels slowly. On the flip side, if we look at the A delta, and you can see this right here, right there, these little yellow thingies, this is myelin. And because there's myelin around these fibers, information can travel much faster along the nerve pathway, letting nociceptive information reach the brain quicker. A key point regarding nerves is that they fire in both directions. And so what you see here is the arrow pointing towards the dendrite, which is this piece right here. Noxious sensory information travels up the nerve. That is proximal firing. That information eventually, potentially, makes its way to the brain. The distal side of things, so closer towards the axon, where we get distal firing, neurogenic inflammatory chemicals are sent down the nerve tract, potentially to the impacted region. And so things such as substance P, CGRP, neurokinin A, and peptides all are carried distally along the nerve tract. This is a contributing factor to neurogenic inflammation. And this type of firing right here occurs predominantly in the C fiber. These neurogenic components mix with non-neurogenic components produced by the immune system. That includes macrophages, lymphocytes, and T cells. And it is the combination of these molecules that create the inflammatory soup in the injured area, helping to promote healing. This is something that I've screwed up in the past, in the sense that I thought you could potentially have only one type of inflammation. But really, these guys work together to help an area heal. Or, in prolonged painful scenarios, continual barrage of this inflammatory soup creation occurs. When these guys mix and the inflammatory soup forms, you get several different things occurring in the area. For example, a combination of these three things increases vasodilation to the area. So we promote blood flow to the area to support healing. It is this vasodilation that leads to the cardinal signs of inflammation occurring. So the area becomes red, it becomes warm, it becomes swollen, it becomes painful, all of these things, because of that inflammatory soup presence. You also get a shift in plasma proteins from the capillaries to the area involved. So it goes from the capillaries to the local area, promoting the healing process. You also get a release of several different chemical mediators, ranging from histamines to magnesium to a lot of different things to also help promote the healing process. And the key piece that leads to inflammatory-based nociceptive pain is you get activation of silent and high-threshold nociceptors, which send nociceptive or noxious stimuli up along its nerve tract, eventually making its way to the brain. It is these nociceptives in particular that make innocuous or easy movements painful. So I sprain my wrist, or I have some type of injury where an inflammatory response occurs in my wrist, and all of a sudden, it's not just gripping objects that's painful, but even when I do that, it hurts. The reason why these easy, simple movements start to hurt is because of activity of these silent and high-threshold nociceptors. And it is their activation that minimizes movement in the inflamed area, promoting the healing process. So, peeps, don't be hating on inflammation. This process is incredibly important to promote the healing process in an area that is injured. If we go back to the proximal firing place, so we talked already about the neurogenic inflammation firing distally, and we remember that noxious sensory information goes proximally. And it goes proximally along this pathway right here. So, here's the nociceptor. This is the nerve. And proximal information, or noxious information, goes up the first order neuron into the dorsal horn of the spinal cord. It then, once it passes through an interneuron, which is kind of like the bouncer, letting certain information pass through versus not, that first order neuron synapses with a second order neuron, which is this green one right here. This second order neuron then makes its way to the spinal thalamic tract right here, and it goes all the way up the spinal cord, eventually making its way to the thalamus. And I believe it's the VPL, the ventral posterior lateral aspect of the thalamus. Once there, it then synapses with a third order neuron. This bad boy goes from the thalamus to the primary somatosensory cortex of the area involved. And so if this is my finger, the information goes to the finger area of the brain and lets you know, hey, brain, I've got something going on here in my finger. I should do something about it. And the brain's like, yeah, you know, pending circumstances, okay, you experience pain based on the nociceptive mechanism. And here's the crazy thing. Along each of these stopping points, something happens, and information becomes less and less clear, much like that telephone game we played as a kid. And the reason why that is because it's not always a straight path. At each connecting point, and where each interneuron is present, there's other neurons touching those areas saying, facilitate this, inhibit this, facilitate that, inhibit that. And what that does is it makes the initial information from the nociceptor become less clear or become less similar to what was initially sent to the first area. And so a lot of times the information, by the time it gets to the brain, is nowhere near close to what was experienced in the periphery. And this is what happens. The brain has to make a decision based on the information given, whether or not we need to experience pain. And sometimes this information doesn't tell the whole story. Sometimes it's completely inaccurate. If you want an inaccurate example, think about when you experience your cell phone vibrating in your pocket and you look and you didn't have a notification. We've all experienced this. This is a misfiring based on misinformation. The same thing can happen with pain. And it is because of this misinformation or this misinterpretation from the nociceptive information to what's actually produced by the brain as to why we can't say nociception and pain are the same thing. Because you can have nociception occur that is incorrect, or maybe non-nociception that is incorrect, or non-nociception occur, both of those potentially leading to pain experiences, and vice versa. Sometimes that information that comes from the primary nociceptor may make its way up to the brain and be incredibly accurate, but for a multitude of reasons that we'll discuss later, pain may not be produced. On the flip side, we can have innocuous stimuli lead to pain experiences that is not nociceptive. For example, in some chronic pain states, you can get or experience pain via noises, via smells, all of these types of things. Nociception and pain are not synonymous, though are oftentimes associated. How do we see what this looks like in the clinic, and what does it present like? The number one factor to say this person probably has a nociceptive mechanism going on is that it's localized to the affective region. So let's go back to my bicep example. Ow, I strained my bicep somehow. I'm doing all the signs and symptoms that would implicate there's a bicep and I only have pain here. Probably a nociceptive mechanism. Other things that could potentially implicate nociception that are less important than these would be clear aggravating or relieving factors. So bicep first with contraction and stretching, sort of touch, and the pain is intermittent. Next, we're going to talk about neuropathic pain. We used to call this peripheral neuropathic pain, but I found the new definition to be much more all-encompassing of some conditions that don't necessarily fit into the nociceptive or central pathways, but still are painful nonetheless. So here's our new definition. Pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. That's sexy. So what does that mean? Well, the reason why they now use a lesion or disease affecting the somatosensory system as opposed to just the peripheral nerves is I want you guys to think of cases such as post-stroke pain or syringomyelia. These are insults to the central nervous system that don't necessarily have a nociceptive mechanism, don't necessarily occur with central sensitization, but yet are painful. They don't really fit anywhere else. That's why we chopped off the peripheral piece and now say neuropathic pain. And there's 4 ways we can get a neuropathic type injury or a neuropathic pain mechanism to occur. Nerve injury, ectopic impulse, cross-excitation, or neurological insult. Let's use this next picture to illustrate the first 3. And so what happens? Nerve injury, okay? And we're going to go back to this. Let's say that this dotted line area is where the myelin gets stripped off the nerve and you get some type of insult to maybe the epineurium or perineurium or something along those lines, some component of the nerve. There's nociceptors that attach to the neural sheath or the thing that encases the nerve. And when the nerve is injured, those guys get activated and act a very similar way to the nociceptive or the nociceptors proper. This could potentially lead to a pain state. Now, an ectopic impulse or an abnormal impulse generated site is very interesting. And so let's say we sever this nerve. And this doesn't have to happen with just a complete nerve resection or a nerve severance. But when the nerve grows back, it doesn't do this. What happens instead is the nerve has several sprouts that come up, hoping one connects. And that's how the nerves heal. This is called Wallerian regeneration. Google that. What can happen is when that occurs, before myelin encapsulates the nerve or encapsulates the sprouts, ion channels, these are various sensors that respond to various stimuli, be it temperature, be it movement, be it stress, surround the nerve to keep the area protected. And sometimes these guys can spontaneously fire, again, creating our proximal distal firing, potentially leading to a pain state. And it has been shown that these impulses or these abnormal impulse generating sites can form on the nerve anywhere from 3 to 21 days after initial nerve injury. And these can happen along the nerve path too if maybe only the myelin sheath was stripped off. Ion channels will form in the area where that was stripped, potentially leading to a pain experience. So there is your ectopic impulse. Now the cool thing is even if I injure one nerve, other nerves that are close or connected somehow to the primarily injured area can also increase their activity levels, stimulate the neural nociceptors, and potentially lead to pain. This could be why sometimes pain can spread, because you get multiple nerves sending these nociceptive signals up to the brain saying, hey, we got some problems there, and you want to take care of that. All of these are neuropathic-based pain states. And then the last one would be some type of central lesion. So let's look at this picture as an example. Here we have a stroke affecting what looks to be the primary somatosensory cortex among some other areas. Could it be that damage to this area could potentially lead to a pain experience? Well, a a lot of people do experience post-stroke pain. This could potentially be one mechanism by that. So there's the ways that you could potentially say someone has a neuropathic pain syndrome occurring. But I'll do you one better. We have a grading criteria based on the literature that would give you more and more evidence to say someone has neuropathic pain. So go ahead and read those right quick while I get a sip of water. And here's the way that this grading system works. If you possess all 4 of those grading criteria, you can say that there is a definite neuropathic pain syndrome occurring. If you possess 1 and 2, so neuroanatomical plausibility, somatosensory or peripheral or central somatosensory system lesion, and you have one of the testing saying that this is true, so whether it's a neuroanatomical distribution test, maybe a neurodynamic test, or an MRI saying that this is the case, then you have a probable neuropathic pain syndrome, or a probable chance, I should say. Now, if you have one of the first 2, and you don't have any testing that would implicate neuropathic pain, then you could say that you have a possible neuropathic pain syndrome occurring. So there's your grading criteria, there's how it works, there's how we can determine whether or not someone is experiencing pain secondary to a neuropathic mechanism. And here would be an example of one of these neuroanatomical tests that we use, such as a neurodynamic test here on Sarah. I'm doing a upper limb neurodynamic test 1, or the base test, which assesses excursion of basically all the nerves of the upper extremity. Last one, the big dog, central sensitization. This is defined as amplification of neural signaling within the central nervous system. So all of the information is turned one way or another that is deviant from norm. Here's how we can look at this a bit more in depth. So, first case where we don't have central sensitization is when input and output match. So you sprain your ankle, it hurts. And it hurts to an extent that we would expect an ankle sprain to occur. This is where the nociceptive input from the ankle matches the output that we get from the brain of pain. But let's say I sprain my ankle, but it's Game 7 of the NBA Finals, man. And we're down, and we want to win. That individual might not experience pain or as much pain from that ankle sprain and make his way and finish playing the game. In this case, we have large nociceptive input coming in from the ankle sprain. But mechanisms occur that say, this is not important, I'm not going to experience pain or as much pain, and we see that input and output do not match. That is also central sensitization. And instead of an amplification, it's a downregulation of potential pain outputs and nociceptive input. On the flip side, let's look at a condition where I have a very small input and I get a large output of pain. Think of paper cut. Ooh, worse than childbirth, they say. I get a small paper cut, very, very small, and wow, it hurts like all hell. Well, what's going on there? There's some type of amplification process occurring that I'm getting small nociceptive input from the area in question, yet I get a large pain response occurring. And then the last, and by far the worst, would be a maintained afferent barrage that leads to a large or prolonged pain experience or outputting of pain. And this might be complex regional pain syndrome as an example. So I have a very small, potentially innocuous insult to the area. Maybe not innocuous is the word, but I have a small insult to the area in question, and all of a sudden I get all of these crazy disproportionate changes in the area, very extreme sensitivity to pain, among other things. This is not something you want to wish on your worst enemy. There's 3 ways that we could potentially get a central sensitization mechanism of pain. We have spinal sensitization, interneuronal death, and forebrain-mediated pain. Let's dive into each. First 2, spinal sensitization and interneuronal death. Now, one thing that I mentioned a little bit here and there when we talked about nociceptive mechanisms, let's dive in, is with this information coming up here and making its way to the dorsal horn, somewhere around here, right in here in most cases, you have this thing, and you can see one right here, called an interneuron. This is actually probably even better. So you see this guy right here, this is an interneuron. And so the interneuron is kind of like the bouncer in the club. You let certain people come in, you let certain people stay put. And it is this guy right here where spinal sensitization occurs. And so what does that mean? Spinal sensitization involves a change in who the interneuron lets in versus letting out. And I can either have it facilitate more nociceptive information in the case of pain, or inhibit nociceptive information in the case of pain. And there's many different mechanisms that could cause this to occur. You have things propriospinally that could have this occur. You have things in the central nervous system. You have heterosegment. You can have a different segment along the spinal cord cause spinal sensitization. Many different things. Let's first talk about inhibition. This would be our ankle sprain example in Game 7 of the NBA Finals. Why, if I have an injury, would that be advantageous? Obviously, we want to win the game. But from a mechanistic standpoint, what do you guys think is the reason why the pain output doesn't occur or occurs minimally? What is more important than pain? And the answer is the fight or flight mechanism. If pain or the perception of pain would impair that mechanism from working to the highest degree, the fight or flight mechanism, the key to our survival when we are under threat, that's a no-go. Because that mechanism is going to allow us to survive, more so than experiencing pain will in many cases. And so in the Game 7 of the NBA Finals case, fight or flight is way more important in this case, and I can't have pain cramp in fight or flight style. So what happens, those pathways that I mentioned previously say, hey, interneuron, don't let that nociceptive information pass. And we have spinal inhibition. Really cool mechanism. What about facilitation? When would I expect spinal facilitation to occur at the interneuron? There's really 2 keys when we're talking about nociceptive processes. One is a continuous barrage of nociceptive input or a strong sensory input of nociception. When these 2 things happen, those pathways that I mentioned think, uh-oh, there's something big here. We really need to figure out what's going on in this area. Interneuron, let them pass. And you get continuous nociceptive information passing through because the interneuron is allowing that to happen. So that's how spinal sensitization works. Now, if I have facilitation occurring, and it keeps going, keeps going, keeps going at that interneuron, glutamate is produced to a very high degree based on the way the nerves interact. And excessive glutamate production is excitotoxic to the interneuron. Then what happens in this case is because so much glutamate is produced in that area, the interneuron dies. And it doesn't grow back. So guess what happens when the bouncer leaves the club? Everybody's going into the park. So I get nociceptors sending their information unabated. up to the central nervous system. I get wide dynamic range neurons. These guys contain both noxious and non-noxious stimuli, making its way up to the same region. This is another reason, this is a central mechanism as to why I get non-noxious or innocuous stimuli in the case of complex regional pain syndrome, maybe just that light touch, leading to a large amount of pain. This also occurs because in these spinal sensitization cases, or in the cases of interneuron death, the C fibers retract from their location in the dorsal horn. Why this is? When I asked David Butler at Explain Pain, he thought that it was an immune reaction. But when that C fiber retracts, A beta fibers, which carry things such as light touch or innocuous stimuli, transpose and start to grow where those C fibers once were. This is another mechanism why things such as light touch can start to hurt. And so you see that the interneuronal death and spinal sensitization can be incredibly deleterious to an individual who is experiencing chronic pain, because you don't have any mechanism that's shutting that off in the spinal cord. Problem. Another cool spinal sensitization mechanism that occurs sometimes is contralateral pain or mirror pain. And what happens here in this case is as the spinal sensitization increases, I get an immune reaction on the contralateral aspect of the spinal cord. Glial cells stimulate tumor necrosis factor alpha in the area of the dorsal horn and the dorsal root ganglion, which is kind of like a mini brain in your spinal cord. And that says, hey, let's bring more nociceptive information on this side. And what happens? Well, my left hip started to hurt, and all of a sudden, I've been walking around, and maybe I've just been compensating, but my right side started to hurt. And there could be some ischemic type things going on in that area, but we definitely know that one factor that leads to that pain occurring on the other side, albeit to a lighter degree, is this immune reaction occurring on the contralateral side, creating a mirror pain. And this happens within 24 hours of someone sustaining an injury. The degree, idiosyncratic. So those are very two big mechanisms, spinal sensitization and interneuronal death, that are a component of central sensitization. The last would be forebrain mediated. Now, many of these areas that I've wrote on this slide, or I guess I've typed, light up when someone is experiencing pain. And in many of these areas, we see that people who are in prolonged pain states, atrophy occurs. This is your forebrain mediated type change. Or maybe some of these pathways get to run a little bit better, such as the amygdala, right, which is often associated with fear. But we get changes occurring within the brain that contribute to the central sensitization process. Basically, the brain helps make the pathway that leads to the pain experience and all the other symptoms I talked about much more effective. Now, the cool thing is if we can get pain to cease, those brain areas start to grow back. So we can appreciate that how plastic, how well the nervous system can change. Even in the case of interneuronal death, we can still get positive changes if we have mechanisms to reduce the painful experience. And it is this piece right here, right, this forebrain mediated pain, all these areas that are active, that a lot of times we talk about as a pain matrix or a neural matrix or a pain neural signature. With these pieces, all this basically says is there is a framework of interconnected areas within the brain that are active when you're experiencing pain, and it all kind of communicates as one. And so if we image the brain and we see that, we'd probably say that that individual is experiencing pain. What does this look like in the clinic? Number one thing, doesn't make sense. This is the pattern of no pattern. So there's no clear aggravating or relieving factors. The pain has been going on for a long period of time. All of these factors start to have me think, yeah, we probably have a central mechanism at play with this person who's experiencing pain. Now, you thought the biopsychosocial model was like, oh yeah, this all makes sense. But don't get us wrong, fam. This model has problems as well that don't necessarily explain certain things. For example, let's look at this graph right here. Here we have different stimuli. We have nociceptive stimuli. We have non-nociceptive stimuli. We have auditory stimuli. We have visual stimuli being imaged in the brain. Here's the thing, and I just mentioned this with this pain matrix and this pain neuromatrix. These all look kind of similar, right? So if you didn't know, if I blocked off all of those things, aside from the cool colors, would you say that this person was experiencing different stimuli? You couldn't necessarily say. And the point being, with this study that was done, was to say that, hey, maybe it's not a pain matrix, maybe these brain areas that are active are involved in a lot of other processes. Moreover, you can have things lead to enhancement or decreasing of pain that aren't necessarily related to some of the processes that I mentioned. For example, your mood state can influence whether or not you have more or less pain. Pungent odors can make you hurt worse in certain painful states. This doesn't make sense based on some of these mechanisms, right? Because these are not necessarily nociceptive stimuli or stimuli that impact that pathway that I talked about in any of those processes. What's going on here? And oh, by the way, that last slide that I showed you, they've been, this group right here, Moreau et al., and I think Iannetti was one of the authors, but he showed that he could produce activation in the neuromatrix that led to pain with auditory and visual stimuli. Pretty cool stuff. How about this, guys? This study right here was awesome. In some people, 96% of the brain is active in a pain experience. That is remarkable. What does that say to some of those areas that I mentioned previously? Do we really have such a thing as a pain neurosignature, neuromatrix, or neurotag? I don't know. The point being is that these brain areas that are active are oftentimes idiosyncratic. And I think what happened when we were discussing the neuromatrix or the neurosignature is that scientists, much like we did when we were first talking about core stability, thought that these things were involved, and that's all they measured. And we didn't measure a lot of these other processes. But my hypothesis in this case is that the areas of the brain are active that are necessary for that organism to survive this threatening instance. And one of my favorite problems, phantom limb pain. Again, phantom limb pain always screwing up everybody's theories. So before, the biopsychosocial model could explain something like phantom limb pain. Okay, they don't have a limb. Well, maybe there's some type of central sensitization mechanism going on that's leading to that individual experiencing pain. And so what do? Well, we do something like we do on the right. We do mirror therapy because there's some good research out there showing that this may help that person in pain. So they don't have a limb to move? Good. Use the mirror, have them watch them move their affected limb. That does some homuncular refreshing in the somatosensory cortex, because there's research out there showing that when the picture of what we look like in our brain gets a little fuzzy, pain is more likely to occur. And so if we make that picture a little bit clearer with something like mirror therapy, we can help people. And so that's exactly what we do with someone who has phantom limb pain. And it works. What about this study? Here, they did injections in the spinal cord. They did injections in the lamina, they did injections at the segment itself, they did injections all in multiple different areas. So think about like a more neuropathic type of treatment paradigm on individuals who have phantom limb pain. Guess what? They got better. They they took it away. How can we have two mechanisms or two treatment paradigms targeting two different mechanisms lead to the same outcome? The point being, with this classification system, is we don't have this divide. It's likely all occurring at once. And that's not something that's not necessarily implicitly clear when we talk about the biopsychosocial model. And if we look at these pain-based mechanism classification systems, per the research, there's nothing to brag about. It's very specific. We can say, yes, this person has it, but we can't necessarily rule out things. And it doesn't do anything from a predictive standpoint. And what I would question for you beautiful, sexy people, is does knowing someone have a nociceptive versus central mechanism at play change your decision making? And if so, how? And upon reflection, for me, it doesn't. Because there's qualities that anyone along this continuum need in order to be a successful mover and reach their health and performance goals. So this isn't it. Well, I think that these classification systems can be helpful in understanding a component of the mechanism of the pain experience. We can't separate them into silos. A more likely case is that these guys are all active at the same time. These processes are all undergoing at the same time, much like the energy systems. And it's really hard for us to say at any one given moment that we have this mechanism going on versus another. And does it impact your decision making? I think that this model, this understanding of how pain works from a pain system level is useful and akin to Newton-based physics. Yeah, even though it's incorrect, it is still a useful thing to utilize in our day-to-day life. But it doesn't tell us the whole story. If the pain classification system is Newton, we need an Einstein. And that's where the super system comes in. The super system is a much more encompassing way to understand not just pain, but how we as human organisms work. And it takes into account and appreciates all of the systems and how all the systems are involved in not just a pain experience, but any experience that we have. In order for us to have an effective super system, and what that is, the super system being the communication of all systems working together to help an organism survive or thrive. If I want to have a good super system, I need three qualities. The first quality is irritability. What irritability is can a system, when there's some threat to homeostasis, go out of its homeostatic value, do what it needs to mitigate the threat, and then return back to normal. For example, let's say you get sick. The immune system, chill, mind its own business. Uh-oh, we got a pathogen here. Fam, let's go get after it. And what do? They act up above their norm. You get an increase in things such as white blood cell count, all these other things to fight the infection. Life's good. I go back to normal, minding my own business. In fact, I get stronger. That would be a component or an irritable subsystem within the super system. And it is that back and forth that makes that system effective. But what happens when I have an immune system that doesn't do that well? Maybe because I'm sleep deprived and my immune system is dampened, I either have this low-grade sickness going on at all times, or I don't even fight certain pathogens. Well, in that case, the immune system is so out of whack and has such low irritability, the system is ineffective. So we want irritability within each individual subsystem. Connectivity. This is how well does each subsystem communicate with one another. An example at which we have good connectivity between systems is the inflammatory process. And so, for example, I sprain my ankle. The nervous system and the immune system send molecules that communicate with one another to create the inflammatory soup, which promotes the healing process of the ankle that I sprained. But what happens in the case of a systemic inflammatory condition or an autoimmune case? Well, there, the communication might not be as good. Or maybe it's going on and on and on and on and on, and problems pursue. There we have poor connectivity between the systems. The last would be plasticity. And what plasticity is can a system adapt to meet the desired needs of the super system? Example, I do my bicep curls and all of a sudden my biceps get huge. That would be an effective muscular system that is incredibly plastic. What about, though, on the flip side, when plasticity goes wrong, I develop arthritis, or I develop an outgrowth of bone near my acromion that impinges on my rotator cuff. That would be a non-desirable plastic adaptation that occurs, making the super system less effective. But we need all three in order for us to work to the degree that we wish. What are things that could make the system or the super system malfunction? These guys right here. You're stressed. Your significant other broke up with you. You do things that maybe you're exercising well beyond your means and you injure yourself because you can't adapt at the rate that you're trying to stimulate yourself. Or maybe in the case of chronic pain, there's things going on saying, we're still in trouble, let's keep producing pain. Any of these things, or a combination of these things, can lead to malfunction within the super system. And in the case of chronic pain, what makes this so complex is that this can occur anywhere. It can occur at any of those systems that are listed surrounding the super system. Could you have an immune reaction that potentially leads to chronic pain or is a contributing factor to chronic pain? Could there be bony changes that show, there's still not an all clear here because I got some type of bony change in my elbow, maybe an arthritic type change at the joint. That could lead to chronic pain. Anything can happen, and that's what makes this pain problem so complex and so individualized. And why does chronic pain come from? Something wrong with the super system. Either I can't regulate some of these stressors that I talked about, and I lack the qualities that I mentioned before of irritability, plasticity, and connectivity, or maybe something like this is going on, right? It is disorganization, dysregulation within the super system that leads to a chronic pain state. It's up to us as clinicians to figure out which of those systems are involved. The big key with the super system is threat. All of those changes that I mentioned to you guys occur because there's some type of threat to homeostatic balance within the super system. It is up to us to mitigate these threats so we can survive at one side and thrive at the other. The key threat piece, what lets my body know that there is something going on, these three things right here. Saliency, so if something is very different from the norm, it's novel, this is new. That's kind of cool. I should probably know something about that. And then, of course, threatening. If a stimuli, whether it's a tissue base or something in the environment, meets one of these criteria, the super system becomes active to deal with that. So, for example, that's probably something salient, right? I get a nail in my finger. Ow! Well, there's several processes that occur when that happens, so the super system can help deal with this threat. This is a few examples. So let's look at the nervous system. Nervous system, the nociceptors in that area detect, we got something going on here. It alters how we move in that area. We get the fight or flight mechanism via the autonomic nervous system kicking in. And I don't want to experience too much pain because I got to go to the ER and get this taken care of. So pain-relieving chemicals, the endogenous opioids and cannabinoids, are produced. And of course, my attention is redirected to the area in question. Little side note, if you take your attention away from the area in question that's hurting, you actually can reduce pain. That's why it's advantageous when you get shots to look away and it doesn't hurt as much. It's actually #EVP, just so you know. Other things that can happen. The endocrine system is very important in this case. So the stress response occurs, and the HPA axis, and all these things that allow us to recover from that insult. The immune system. We know its response and inflammation, but it also is an opioid producer, and it doesn't worry about necessarily external threats, but if I have some type of internal threat in my body, whether it's a pathogen or something else, the immune system knows about it. Very important system. And my favorite, the PT special, the motor system. We get an alteration in variability. What does that mean? Well, in an initial injury, in acute stages, variability is reduced to what? Protect the area in question. Okay? Can't move it as many degrees of freedom. More likely to heal. In chronic states, I actually get excessive variability. So I lose control and coordination. This is very accurate with a lot of the motor control research we're seeing in people who have had back pain but still have changes in movement. Altered activity. Let's talk about that. In the acute scenario, let's say I hurt my bicep. The amount of activity within that bicep muscle is initially reduced. Makes sense, right? I don't want to have a crazy amount of activity in this area, I just tore my bicep. In the chronic state, or in the prolonged pain states, we actually get continuous overactivity of the areas in question. So muscle tone increases to a high degree. This can potentially lead to ischemic responses, and it's not just the impacted area, but it's also synergists in areas surrounding the area. And I would argue it occurs as a whole body response. But it is this process right here that could potentially lead to ischemic-based pain from overactive muscle groups. So this could be another factor as to why you may get spreading pain or pain that occurs in non-involved areas. You also get changes in proprioception and motor control. Another thing that I like about the super system, it explains pain-based behaviors and states that central sensitization cannot. So we can think of pain mechanisms occurring either as non-associative or associative. And central sensitization is non-associative. So I have habituation to a stimulus, right? I keep doing this thing and pain increases because of amplification of these processes. And then I have some type of sensitization to a particular stimulus. But one thing that central sensitization cannot explain is the associative-based pain state, or pain processes, or other processes that are related to pain. And classical conditioning is a prime example. Let's say every time I bend forward, I experience pain. What may happen is, as I keep running that pathway, I may condition myself to say, wow, I'm not going to do that activity because I know I'm going to do that. I could potentially experience pain. Or I think about bending forward and I experience pain. These are not processes secondary to central sensitization, but a conditioning-based paradigm. So I've created pathways in my brain that are not necessarily some of the central mechanisms I've discussed previously that potentially lead to an increased pain experience or other things associated with pain, such as fear avoidance. Fear avoidance fits this model, but it doesn't necessarily fit a central-based mechanism. So another way that we can have the super system at play. Smudging. Also, believe it or not, guys, not a central sensitization phenomenon. And so I mentioned this briefly a couple times, but when I don't use an area, picture of what that looks like in my primary somatosensory cortex and in my primary motor cortex becomes a little fuzzy. This is not a process of central sensitization, but a process of disuse. And when I have disuse in an area, I'm much more likely to experience pain. So we can see how the motor system and the central nervous system are very much connected. Now, what makes this complicated or complex, even more so than I've already probably made it, is you have all of these things as potential contributing factors to pain and disability. All these are weak links, but links nonetheless. From a genetic standpoint, there's been some research out there showing altered methylation or histone modification potentially lead to chronic pain. In animal studies, if the animal has sustained a very salient situation, or like think like a traumatizing event, that's led them to be more likely to experience chronic pain or chronic nociception or things along those lines in the long term. All of these things, right? Those are just a couple examples. The point being is that there are many factors that can go into why someone might develop a chronic pain syndrome, and the supersystem plays a huge role in that. What I want to illustrate to you guys, most importantly, is that this is a very complex problem, and a lot of times revolves complex solutions in some of the worst cases, because there's multiple systems that have to be addressed. And I think that's one thing that we're not doing a good job of, myself included. That's why I'm looking to some of the other things that I'm looking to personally. So what do we do about it? Right, Zach? You said you were going to explain all this, and yes, it is complex. How are you going to help your patients with that? Now, do I think you need to explain the supersystem to them? No, I don't. But I need you guys to understand just how complex pain is. And if you understand the mechanisms, at least what we think about in regards to pain production, you can take those concepts and apply it in a simple, to understand fashion to your patients. And if you can empower your patients with knowledge, that's step one to getting them on the path to pain freedom and helping them meet their health and performance goals. This is my model right here. I've adapted some of this from Chris Kresser, so shout out to him. But what I think with this model is these are some of the ways that we can intervene as movement-based practitioners and some of the practitioners that we are to maximize someone's performance or health. You'll see in the middle that I have these two things divided, performance and health. And the reason why that is because, well, yes, you can improve both up to a point. Eventually, you have to make a decision. Do I want to maximize my performance to a high degree, or do I want to become incredibly healthy? An example of this. Let's say you're a bodybuilder. You're getting after, you're getting some big muscles. You want a few small shows, but you got your eyes on Mr. Olympia. You are highly likely going to have to take super physiological doses of steroids to be able to do that. That's very well established, because you just cannot get that big unless you use those things. There's potential that those super physiologic doses of steroids could have deleterious consequences to your body in the long term. So here we see someone who wants to perform at a high level at the expense of health. On the flip side, there's some good research out there, or at least some research out there, showing that if you consume a lower calorie diet, or you do a lot of intermittent fasting, that could potentially extend your lifespan. But I guarantee you will not perform at the highest level in a given sport by doing that, because you just don't have enough fuel. There's trade-offs with this. And so that's why performance and health are divided at a point. These are some of the ways that I think we can impact someone's health or performance goals. Obviously, sleep is very important, supportive nutrition, managing stressors. This is a new one that I'm kind of getting into with social support and having a good social network, kind of a big deal for health, among other things. And of course, our domain as movement practitioners, physical activity. If we break down physical activity, I think that there's 4 qualities that we can improve someone's physical activity by. Knowledge, so does someone understand the aspects necessary to perform a given task? Variability, which is can that individual move within a range necessary to perform a task or through enough degrees of freedom necessary to perform a task? Power, the ability to produce intensity, and then capacity, the ability to sustain intensity. And I think that it occurs among a sequential fashion, or at least it ought to. So you make sure you have not missed any steps towards increasing physical activity levels in such a manner that it improves health and performance. Now, where does all my talk fit? I think it fits in the knowledge piece. And I think that this piece is the most important along this continuum. Because guess what? What if your patient or your client believes that if they deadlift, it's going to break their back? Clearly, that is a maladaptive knowledge process. And there's no way you're going to be able to address anything down the continuum unless you squash that maladaptive belief. And that's what I'm going to teach you guys how to do with all of the knowledge that we've acquired in my prior portion of the talk. Sad thing, not good evidence for education, guys. Spoiler alert. There's a lot of studies to support that education doesn't work. But here's the deal. The type of education that you utilize matters. And many of the studies right here that show that education doesn't work use the biomedical model to explain pain. We know that's a bunch of baloney. In fact, it's been shown that it doesn't work. It increases fear, stress, and anxiety, and leads to increased pain. So it's clear that Rene Descartes, well-intentioned, actually making some people worse by explaining pain mechanisms with this process. We need something better. Because guess what, guys? The things that we tell our patients are beliefs, their beliefs. And if we communicate potential beliefs poorly, these factors and the combination of these factors have been shown to increase chronic pain level. We cannot be a part of the problem. I love this study here. Let's read this, guys. A number of factors influence the participants' beliefs. The clinicians appear to be the most important, and that's clinicians' beliefs. So what we say can have a profound impact in what our clients think is going on. Because many times, especially if we're the first person they've seen, they trust us as practitioners. They trust that we have the schooling, we have the knowledge base, we have the experience to help them. And if we give them a belief that's maladaptive, we're potentially screwing them over for a very long time. Because, as I'm sure a lot of you guys have found, these maladaptive beliefs just don't go away when you say, oh yeah, well, it's a super system, bro. It doesn't mean that you have to hurt it. It doesn't work that way. And so it's imperative that we give our people accurate information that is non-threatening. In the same study, this was one of the participants. When the current episode first happened, the only thing that was going through my mind is the seriousness of my disalignment of my back. I was really petrified. You get scared in the sense that you could damage your spinal cord or anything to such an extent that you might become paralyzed. How are you going to get someone to improve their variability or do high-intensity continuous step-ups if this is what they think is going on with their back? I feel pity for this patient. And we cannot get our people to the point where they're thinking these types of things. And this is why our explanations matter. Because we could have this happen. And this type of maladaptive belief is very, very hard to break. We have to be mindful of the words we choose to use with the people that we work with. Because you'd be surprised what they take to heart. Pain neurobiology education kind of works, guys. It's been shown to decrease pain in the short term. Patients are happier, meet some of their needs, and they feel safe, right? They're more willing to move. So if we educate them on how pain works, it might be possibly helpful for them to potentially undo some of those maladaptive beliefs that are impacting their movement capabilities. But we can't just educate, guys. This is where a lot of people who purport some of this information go wrong. It's been shown that it doesn't work alone. In fact, after 3 months time period of using explained pain-based intervention or educating on pain neurophysiology, it doesn't work. What do you do after that if they're still hurting? That's why we cannot neglect movement. We cannot neglect building fitness and resiliency and all the other factors involved, because we still have things to address within the super system. Now, talk to me 2 years ago, or a few years ago, I did a talk called Smooth Talker. How about that? And I used to explain pain with a lot of this stuff, or talk about pain mechanisms with a lot of this stuff. In fact, there's a study out there, I believe it's the seductive allure of neuroscience, where even if you give them an inaccurate explanation that involves the brain, you get a little bit more buy-in. But I found that this stuff muddies the water too much. And we don't have to go that in depth to eliminate the maladaptive belief, because that's really the goal of this educational process, is to give our patients and our clients helpful beliefs that allow them to meet their performance and health goals. We don't need to make them a pain scientist. I keep it simple, fam. And that's what I'm going to show you guys. What I advocate instead is an impairment-based model of educating our patients. And so what does that mean? You take their maladaptive belief, you explain it in such a manner that they realize that that's false, and they move on to a healthier belief. And you only address the beliefs that are maladaptive. You don't need to address anything else. For the goal, we want to redirect attention. And so they have their attention on this maladaptive belief that pain and tissue damage are synonymous. I want to bring them over here. How am I going to redirect it? With a salient input. See how I get that threat matrix kicking in? A salient input of, oh, maybe that belief's incorrect because of this. Oh, okay. Boom. Guess what happens? We get activity of the super system kicking in. We get changes in the brain because we've altered their perception of what's going on. Very powerful. And then alter the context, right? And say, oh, hey, well, what about this? Then I say, alter context. Okay, let's tell you what's really going on, and let's change how you think about movement and how you're moving in such a manner that it's more productive than your current strategy. And then this is where getting power, variability, power, and capacity improve. We improve the qualities that make our individuals resilient and make them stronger, that help them meet their health and performance goals. And this is the process. Once you got your knowledge out of the way, get at it. Now that said, I wish I had a one-size-fits-all thing for you guys. Because as both of us know, we understand things differently based on whatever metaphor our teachers gave us or things that we've read. If you and I read the same book, we're going to get different things out of it. Something might be impactful for me that's not for you. So we have to make sure that however we explain things to our clients and our patients, that it's individualized and catered to them and in such a manner that's meaningful to them. We have to meet them where they're at. We have to meet them at their story. And what I mean by that is wherever their belief is at, you have to find some way, shape, or form to acknowledge what their thought process is, and then slowly bring them back to where you want them to go so they can meet their health and performance goals. Now that said, in my clinical experience, I found a few different methods and a few different metaphors and explanations that have been effective for a lot of different people. And there's many things that people have from a maladaptive belief standpoint that are quite common. If we can squash them, then we're in business to get after it from a movement standpoint. So let's dive in. Problem number one. When I'm feeling pain, I'm injuring myself. Oh, my neck hurts. I think I broke my neck. Clearly that's wrong. How do I let them know that that's wrong? I give them examples in which that's not true. For example, how many of us have had a pebble stuck in our shoe? And, we're walking around my but ow, right? It hurts. What do? You take the pebble out of your shoe, life's good. And when you experience pain in your foot from that pebble, was your foot damaged? No, of course, back, right? Well, guess what? That doesn't fit what you're thinking, right? When I feel pain, I'm injuring myself. But here is an example where you are feeling pain, but yet there's not really an injury of tissue. Another example. Let's say, it's Blackout Wednesday. We just had Thanksgiving recently. It's Blackout Wednesday. You decided to, go party hard. You wanted to do some time in Vegas, have a little bit of fun. And you wake up the next morning with this massive headache. I had way too many O'Douls. What tissue did you injure there? The answer is none, right? You got a headache, a painful experience from drinking too much. These things don't match. You didn't injure anything in your head, yet that's where you experience pain because of some other processes that threaten your survival. And of course, another one, heartbreak. Maybe the heartbreak from hearing a Carlos Mencia joke. I have something happen to me emotionally and I feel real pain. What structure is involved? Broken heart? I don't think so. There's something else going on. And here's another example which we can say pain and tissue damage are not synonymous. Problems 2 and 3. Oh, it hurts and pain, I'm not going to do that. Or, hurts my bed for shit, I'm going to do that all day or day. No pain, no gain. Both of these are maladaptive processes. What do you do about them? Solution, find the middle ground. Let's look at this a little bit more in depth. So, if it hurts, don't do it. And this is what I do when I have someone who has this thought process. So, let's look at this graph. You have activity level increasing as you go up the y-axis and along the x-axis time. If I am never going anywhere near the pain threshold, my tissues become deconditioned. And what happens is then when I try to do some type of activity that's a little bit above my norm, because the tissues have become deconditioned, deconditioning is perceived as some type of threat, I am likely to experience pain at an earlier time period or with less activity. This is not good. On the flip side, no pain, no gain isn't good either. So what might happen with this person is I do a large amount of activity and then I have to rest for 3 days because I did way too much and I hurt so bad. And I keep doing this over and over again. Your super system is too smart for that because guess what? It's going to tell you, hey, you idiot, you don't want to keep doing this over and over again. So guess what? I'm going to reduce the pain threshold so you experience pain much sooner so you stop and you don't hurt yourself. The same process as if it hurts, don't do it, occurs with no pain, no gain. The solution is to do the exact opposite of both of those strategies. We want to take it to the barrier. We want to knock on the door of where we're experiencing a little bit of discomfort. Okay, yeah, that hurts a little bit. I just don't worry. That's okay. I'm going to do some activity still. I'm going to get moving. I'm going to respect that. I felt pain during that. But I want to keep touching, teasing, exploring my movement capabilities. And what that does eventually is as our conditioning builds, we realize that these movements aren't as threatening as we thought they were. The threshold at which we experience pain increases. And we keep building on that pathway. And if you do that, you're more likely to increase your activity levels without experiencing pain. How about this one? Yeah, I know I'm not damaging myself when I move my neck, but I just hate the feeling of it. And I don't want to do it because it hurts. What do you do with these people? Respect. You respect pain. What I tell these people is I give them these types of metaphors because we have to realize that, yes, pain doesn't mean tissue damage and it's there to protect us. But a lot of times, pain is there to protect us before tissue damage occurs. If we push through it, we could potentially injure ourselves. Think about it. Think about when you work out, right? I do bicep curls, and it's hurting really, really bad. Well, at some point in time, if I do them too much, there's potential that I could create injury in that area. That is not good. So we have to acknowledge that, hey, look, there's a reason why pain sucks. And it sucks because it's there to protect you from injuring yourself. And so here's what I want you to do. You can either on the left use the pool analogy, which is like, look, you don't have to push through this. I want you to pretend like you are sticking your foot in a tub or some type of pool to test the temperature. Just make sure that it's okay for you to go in there. I want you to have that mindset when you're moving around. Yeah, I know my neck hurts when I turn, but what if I only turn a little bit? Oh, that's not so bad. Cool. You stuck your toe in the pool, and that's a good temperature to work with. Let's move in that arena, and then we'll go from there. Or another one, my favorite, imagine pain is a house of pain, not Tyler Perry, though. I want you to knock on the door. So just, okay, I'm going to test this out, see how things go. It's not useful to bust down the door, no pain, no gain. But I also don't want to play on the lawn either, because I don't get to increase that threshold, inevitably helping me improve in the long haul. What about this one? You give your fancy schmancy neuroscience explanation. You talk about ion channels. You talk about the emergent properties of the brain. Well done, Ducky. And then Sam looks at you and is like, saying it's all in my head? I'm making this shit up? What do you do in that case? Solution is prevention. And it is this right here. It is potentially putting this in their mind. Why I've eliminated those explanations from my paradigm. And guess what? You can still be very effective and still give meaningful explanations despite not bringing the brain into play. For example, there was a study done where they took people who had whiplash disorders, had an immediate whiplash, and they ran them an educational video. And this educational video didn't talk a lick about the brain. In fact, you guys will love this, talked about trigger points and many other processes and tissue healing periods, all these types of things. And guess what? It still worked. Those people who received that educational video did better than those who did not. And the key that the researchers surmised as to why that was because they had expectations. They knew that at week 3 they were going to have a trigger point and that may potentially tighten things up. Don't worry, your therapist is going to take care of that. They knew all of these things. And if you can meet or give people or let people know what to expect with this type of condition, you don't run into these types of problems where they're thinking it's all in their head. Many ways of explanation still work. We just want to ensure that our people don't have maladaptive beliefs. So prevention is key in this case. Less is more. Only bring in the neurology if you have to. But let's say that you got ambitious and you already screwed up and made this mistake. What I would do in this case is you have to use other comparative analogies to say, hey, look, I didn't say this was in your head. And an example you could use is hunger. Hunger does not occur in the stomach. Hunger is an output by your brain. And for example, right, you haven't eaten in a while, signals from your stomach make its way up to your brain and say, hey, we need to eat, or your other tissues, right? And then hunger, the thought of hunger is produced by the brain to let you know you should eat. Or another example is love. You experienced love before, right? What location does love occur? The genitals? No, right? Love is something that's produced by the brain because of a multitude of factors. And we can use these analogies to say pain works in a very similar fashion. Doesn't mean that it's not real. It is real. It's just where is it produced? Information from your body comes in and says, hey, you might be in trouble here. And then the brain has to make a decision and say, oh, okay, yeah, let's do something about it. And you could potentially give some examples of when these two things don't match, right? So you might have someone with a large injury, little pain, large injury. Some of the things that I've mentioned previously, it's like the war vets or maybe stubbing the toe. So the point being is we just want to make sure that these guys have things that they can relate to that help undo the maladaptive belief that you're essentially creative or that's iatrogenic. How about this one? Let's call it quits. I stubbed my toe, my life is over. Hashtag pain catastrophization to represent the nation. This is also a maladaptive thing. The solution? Cuts and Michael Jordan. What else? And so, obviously, when someone's catastrophizing, this is not a good belief because they're thinking that this is never going to get better. And we know, based on the research, that pain typically does get better with time. And so you can give them this example with the cut. Say, hey, yeah, I know it sucks that you stubbed your toe. Let me ask you this. Have you ever had a cut before? You're going to say, well, yeah, sure, Zach, I've had a cut. Then you say, oh, did that cut ever not heal? Or have you ever had one that didn't heal? Look around it. No, they all heal, right? Because otherwise you'd still be bleeding. And so then you can use that example to say, well, look, you've had lots of injuries to yourself that have healed in time. What makes you think that this injury or this pain that you're experiencing wouldn't face a similar, be in a similar scenario? And they're like, no, yeah, I guess that makes sense. So you're just giving them hope. Of course, Michael Jordan. Why can't you use Michael Jordan? You gotta have him in your PowerPoint, especially if you're from Illinois like me. Michael Jordan, as the story goes, didn't make the varsity team his sophomore year. He didn't make JV. And so what happened? Well, he worked hard the following year, and guess what? He made varsity team, and obviously he became the greatest basketball player of all time because of his work ethic. Had he quit when he was down at his low point, we wouldn't have the undisputed greatest basketball player of all time. Yes, undisputed. He didn't give up. You can't give up in this case either. Because if you give up now because you are experiencing pain and you don't try to do everything in your power to get yourself back to how you were, you're never going to meet your health and performance goals. You're never going to contribute to society the way you want to. Thank you, Michael Jordan. These are two very salient examples that can work for someone who's catastrophizing in pain. But it's bone-on-bone arthritis, Zach. Didn't you see the x-ray? Here, you want my MRI too? No, I don't. How do I beat this one? Of course, you got to let them know that these two things don't always match. For example, there's some good research out there showing that the association between arthritis and pain in an area is not always good. Now, that doesn't mean that there aren't people who have severe arthritis and have a lot of pain, because let's face it, total hip, total knees, they kind of work, right? The point being is it's not super clear in terms of how associated these two processes are. Moreover, if we look at some of the back pain research, about, I believe it's 40% of individuals who experience, or 40% of 20-year-olds, somewhere between 20 and 40% of those people have degenerative or arthritic changes in their spine. But does that mean all of those people have back pain? At age 80, 96% of the population that age has degenerative changes in the spine. Does 90% of 80-year-olds have back pain? The answer to both of those is no. Point being is you want to give examples at which you have imaging and you have asymptomatic people, and it doesn't always match. And even though there's some research out there coming out saying that, well, in people who do have pain, a larger portion of those have tissue damage or alterations in tissue. We can use the asymptomatic population to give our patients hope, to say, hey, look, yeah, these could potentially be contributing factors to your pain. But there's a lot of people who don't have pain that have those factors. What's to say that you can't be one of those people? And that's how I'm framing this concept now, as opposed to discrediting these anatomical changes, because they likely are meaningful. We just have to let them know that this is not the end for them and what their goals are and meeting their goals. How about this one? I just didn't do anything. I just started hurting. Well, remember our little ion channel and ectopic impulse discussion? There's your explanation for that. Now you know that, well, ion channels form in the area and those guys can randomly discharge. Good news. Myelin reforms. Those ion channels change every 24 to 48 hours, and then can change them positively with movement, with laughter, with good nutrition, with sleep. We can change those things and help reduce those types of impulses and inputs, or outputs, I should say, from a curve. What about this one? I just hurt my left hip, so why does my right hurt now? Am I compensating? Maybe. Or maybe you can explain to them that, well, actually, there's some research out there showing that the immune system kicks into high gear when you're in pain, and that leads to a mirror pain occurring, much like I discussed previously. And I've been doing this a lot lately, and people are kind of fascinated by that, because I think we understand that the immune system is something that's very changing and is there to help us. And so we could potentially say to our people, hey, now that you know this, well, guess what? If we do immune-boosting activities, whether it's laughter, whether it's exercise, all these things, we can potentially calm that down. Giving them hope, guys. Giving them hope. That's all you're doing, and you're addressing maladaptive beliefs. How about this one? Oh, my gosh! It started in my elbow, now it's in my whole hand and my whole arm. What am I going to do? I'm glad you asked. We can use these types of explanations to help our patients understand why, because they're likely thinking, stuff must be really bad in this arm. No, they're very protective in these cases. The CEO is a good example. So, for example, if there's a problem in a department, the CEO, the brain, may want to know about this. Say, hey, what's going on here? And so what might happen? Some of those spinal sensitization mechanisms might kick into high gear, saying, I want to know more nociceptive information about some of the surrounding tissues. Okay, guess what? I get more information coming in from those areas. Maybe the CEO, the brain says, yeah, we should probably start producing pain here just to really be on the safe side. And so this can potentially be good for people. You want to watch, though, with this explanation, depending on who you give it to, because some people, blue-collar workers maybe, or people who don't respect the man, they might not resonate with that. What's probably a safer bet would be picture next to that, the houses. And so we can use the alarm system analogy in this case to help our clients understand what's going on. For example, let's say one of these houses gets burglarized, and they had a home security system in place. All of a sudden, this alarm system is going, and it keeps going, and it keeps going, and it keeps going. It's really loud. What do you think is going to happen to the neighbors? They're probably going to wake up and wonder what the heck's going on. Right? And there's Gaga commotion now going on in their house. And, what is going on with our neighbors? And what happens with those neighbors, so on and so forth. We can use either of these explanations to illustrate to our patients and our clients that, hey, this is a normal process, it's a protective process. And sometimes just having that understanding can be enough to reduce threat. How about this one? How do I know when I've hurt myself? That's right. Pain is there to protect us, and sometimes pain is associated with tissue damage. We use the Twin Peaks model, which I liberally use. Thank you to Lorna and David. So think about this, guys. As we climb up these mountains, I know, wonderful drawings, right? As we climb up these mountains with more activity, eventually we're going to experience pain. And it usually occurs before the tissue fails. So think like when you exercise, right? You're moving some weight and you start to feel the burn. That's the pain that's produced, and then eventually those tissues may fail. What happens after an injury is because the tissue is healing and it becomes deconditioned, it takes less and less activity for the tissue to re-injure itself. But here's the cool thing. Pain threshold drops way, way down, as you can see there. There's a huge gap between when pain is produced versus when the tissue fails. This is protective. So we don't get anywhere near close to injuring the tissues or making the same mistake twice. Now, that said, we still have to respect pain because guess what? Like, wow, I know that I'm not going to hurt myself. I'm just going to go for it. Well, eventually what can happen is before I get to tissue failure, I may get a large flare-up in symptoms where I get some of those inflammatory processes kick in, I get a large response to pain, so on and so forth. This is like the last straw, like, hey man, you're really pushing that. Let's do some stuff to make sure you don't get back to where you were. So we have to be respectful that we could flare up things and potentially make things worse. These do happen. You don't necessarily need to freak out about it because remember, we still likely didn't hit the tissue failure mark, but we have to be respectful of pain. And so know that pain is there to protect you. Know that just because you feel it doesn't mean you're injuring yourself. And as long as you respect pain, move within its constraints, and continue to try to build and test the waters, you're going to be okay. How about this one? The back went out. There's a couple problems with this. One, the word the. See, disembodiment, they're not loving, they're not respecting the area as much, they're not thinking it's a part of us, and the maladaptive belief of it went out. So what do I say here? Where to go? Almost everyone laughs when I say this. And I use humor to de-threaten this, because we got two big things here. We say, where did it go? Because that laughter helps meet them at their story, and then we can kind of explain, look, backs don't go out, the spine is a resilient structure, so on and so forth. And then we also want to be mindful of saying, like, it's not the back, it's your back, right? This is a part of you. You have to respect it and love it. And potentially saying that it's not a part of you could be maladaptive and may actually increase your pain. And we want to make our patients well aware of that. And so I make sure I emphasize that throughout the entire therapeutic interaction, in the sense that I will always say your shoulder or your neck, even when I'm first meeting them. So I'll say, how may I help you? And be like, how long has your knee been hurting? So always use your, not the, and try to encourage your patients and clients to do the same. Last one. I want absolutely no pain. How many people do we work with that have this belief? And I want to show you guys that this is maladaptive as well. This quote from this great article on the futility/utility of pain. This is from the author. If there's too much pain, then we cannot focus at all. But if we want there to be no pain, we suffer endlessly trying to make it disappear. That is addiction. We doctors are uncomfortable seeing pain. You want 0 out of 10 for our patients. We are a part of it being a problem. There's a difference between suffering because of pain and experiencing a few aches and pains that don't necessarily impact our lives. And if we focus solely on the reduction of pain at the expense of improving health performance and meeting the goals of our patients, we do them a disservice because we are contributing to the problem. And so the solution is we have to reframe pain differently and reframe what our focuses are in the therapeutic interaction. We use exercise to say pain is good, right? You do something that's challenging, that hurts, and your body becomes more resilient for it. We say pain is protective. Think about cancer. How many people do we know didn't feel pain because of cancer until it was too late? What if pain was produced early on in the pathological process? Maybe that could have been there to help them. Pain is good. Pain is protective. And lastly, if if we focus on goals, the goals of the client, hey, not I want to be completely pain-free, but what would that do for you? If you were pain-free, what kind of activities would you get back to that you're not doing right now? Or maybe, hey, maybe despite you still hurting, you can still do those activities. Focus on the goals, because that gives us something to shoot for. That gives us something to focus on from a movement-based standpoint. That gives us something to focus on that helps improve health and performance. So summarize. Pain, very complex topic. And this, I'm sure, will be dated as soon as this goes out on the interwebs. But point being is there's a lot of processes that go into your experience of pain versus someone else. And it's likely idiosyncratic and likely involves an idiosyncratic fix. But if we can take even a fraction of that knowledge and give it to our patients in such a manner that is clear, concise, easy to understand, and most importantly, effective at squashing a maladaptive belief, then our clients have power. Then our clients can move down that movement pathway, focusing on improving variability, power, and capacity. Because it's these qualities and the knowledge to know that I'm not hurting myself and I can move in such a manner that it is helpful to me, that's going to help our clients in the long term meet their goals of health and or performance. If you don't think that this educational piece matters, read this right here from a patient of mine. Let's look at the highlighted portion in particular. I have to tell you, the two things that I took away that are most helpful, besides the camel, that was an exercise that I gave her, was that you aren't re-injuring, it's your nervous system telling you danger, and knock on the door of pain. So helpful. These beliefs, I hope, are beliefs that stick with this woman throughout her lifespan. Because if she took those two things away, anytime she hurts and she has that paradigm in her mind, she's going to have a better outcome because she knows how to attack this problem. It is important what we say. Thank you so much for listening to my talk. If you have any questions about this, assuming you signed up for my newsletter to get this, just hit reply. I'd love to answer them and see if we can get some clarification on some of the things that I discuss. If you want to learn more, here's my spots you can find me, zachcouples.com. Obviously, you likely subscribe to the newsletter, so thank you for that. You're going to get much more exclusive material just like this. Okay. Also, while you're on the website, I offer some online services. So if you need mentoring, I work with quite a few coaches and clinicians at helping answer various questions, some of them related to pain, like I discussed today. I offer movement consultations. So if you're a little tighter than you normally like to be, maybe you've tried some clinicians and you want something that's a little bit more of a fresh approach, I can be that guy for you. And I also offer online fitness training. If you're post-rehab, if you want to lose some fat, or if you want to increase your athletic performance, give me a call. I'll help you out with that. Otherwise, check me out on these social media spots. I post some things on there that I may not post on the website, or at least eventually make its way to the website, and we'll stay in touch that way. Otherwise, thank you so much for listening. I enjoyed this talk. I hope you guys enjoyed this talk as well, and I hope you got a lot out of it. And please comment on any of the mediums you choose so I can get better. And if you have any feedback for me, please let me know. And let me know what you thought. Deuces.